what are your coverage criteria for PCSK9 use? What are they?
Label. So they either have FH or they have ASCVD.
Okay.
And we are allowing physician attestation, so we're not.
So you're not requiring genetic testing?
No, we're not.
Okay.
So pretty simple. They have to have an LDL, an elevated LDL, either 100 or 70, based on whether or not they have risk factors, and they have to be on a statin, maximal dose statin.
So if he calls you up and says, I got a patient here who's on a statin, pretty much maximal statin, with an LDL of 100, and I will attest that he's got a family history and he's got other evidence of FH, for example. I want him to go on a PCSK9. That's all you need?
Yep.
That's
And
fair.
actually, and even
That's
with
it?
Well, I mean, I think that's fair. I think, from a prescriber standpoint, I think, just speaking of private practice, I think we see it as difficult. So the prior auth process is difficult, and I think the simpler it gets made, the easier. So I think, to me, that's a simple process. I mean, to me, when you're in a private practice setting and you're prescribing, it's almost like you're trying to create hoops to jump through so that you don't prescribe it type thing. And I think that's the attitude. And I think there has to be education of the prescribers that that's really not the case. But I think the more simple that prior auth situation is.
I mean, there are payers who have different incentives, and they may have more restrictive criteria.
Right.
But generally, reflecting the label is what I would imagine what most payers do. The only other thing that I've seen a lot of is the requirement of 2 statins or a statin plus ezetimibe as a step therapy before.
There was a sharp
PCSK9.
intake of
Yes.
breath to my right. What was that about?
So I have criteria here that is from a large payer, and this is the hurdle for the patients. So for the familial
Can
patients,
we just stipulate that's not you? Just for the
That's it.
record.
this is not, so has to be disease documentation, LDLR DNA sequencing test, or a mutation analysis, along with, and you mentioned the Dutch lipid greater than 8,
That's correct.
and Simon-Broom criteria needs to be met, along with LDL greater than 100 for 60 days, and trial failure to high-intensity
Just one.
statins.
So
That's
See the
pretty-
hoops?
So there's going beyond the attestation
But
and
that's,
requiring
Right.
this is familial, right? And then for the ASCVD, a major risk score greater than or equal to 15, or the Framingham score greater than or equal to 20. So when we have patients who need this type of documentation, they don't meet the criteria. So that's in there in the 80% that gets denied.
So my question is for the genetic testing, are the payers paying for that? Because that's a hoop. That's a whole
Exactly.
different hoop.
Not to mention just doing that in a busy primary care practice. You don't have time to do it. So what does the physician do?
Call
Not do it.
her.
Oh, there's another criteria that we didn't mention.
What's that?
Is that we still require, and I think most payers still require, that there is the prescription comes from a specialist or at least a consult.
Oh, so
So-
you're not going to let
We're not
primary
gonna,
care
we're not going to let the
physicians
primary
prescribe
care
this?
physician who spends 5 minutes with a patient dealing with diabetes and 5 other disease states prescribe these initially. So I don't see any reason why these shouldn't be a primary care drug, other than they're expensive, and so that is a criteria that's often put into PAs.
But that's going to cost as well. Who's going to pay for the visit to the cardiologist? You're going to pay for that? Mm-hmm. Oh, okay.
An office visit is relatively inexpensive.
All right, so then if the cardiologist comes back and says, give the drug, then you're going to give the drug. But if a fully licensed primary care, perhaps operating in an area where there are very few specialists,
Right?
wants to give this drug, you're going to say,
Right now, no.
drive 200 miles, go see your cardiologist? You going to help with that?
Unfortunately, that's part of the initial 80% that gets denied, and then the ultimate almost 60% that gets denied. There's no way around the payer criteria.
All right, so when we actually push back, I don't mean we, when one pushes back on these 80% denials, at this point, and I'm assuming that you're part of this team that's helping put together a package to get this approved for a patient that you deem worthy. At the end of the day, how many patients get approved?
I think the study was put out or was released by some folks out in California that said 57% ultimately get approved. And I should say that for the 2 drugs that we have available today, there are programs in place that help prescribers and patients to work through these barriers for access and help them work with their provider for appropriate utilization.
Yeah. And that gets back to my what you interpreted as a slam on SPs, which wasn't.
Okay.
Is that
Well, this is your opportunity to explain.
is
We're
just
an equal opportunity
you know,
explainer.
if there's somebody helping the patient, the provider do that, that's great. But when we get form letters in, and you know, a doctor, we get same letter from 2 doctors, and it's driven by, it's put, you know, then we become skeptical on some of these other helpers in trying to get through the process.
I mean, a form letter is a form letter. If it's accurate, no? Or you just don't like the fact you see the same wording in both letters?
Yeah, from 2 different patients, 2 different providers, it's written by a pharma company or something else. I mean,
Okay.
yeah, that's not individualized to the patient into the case.
I again would say that's going to be the exception rather than the rule, because audit processes just would not allow that in an accredited specialty pharmacy. But you have to remember as well, these drugs aren't necessarily in specialty, right? This is a broad channel
Right.
drug product. Sometimes they're being routed into specialty by payers, but many of these are finding their way into other settings. So
So are you saying that if somebody goes to Alan Lil's Starlight Lounge and All Night Pharmacy,
Sure.
compared to the specialty pharmacy, they're less likely to get this drug, even though their need may be the same compared to going to a specialty pharmacy?
I'm not really saying that, because I think that there are supportive measures in place to help patients and prescribers with the initial prior authorizations and then appeals if needed. So I think that patients have access. I just think that there's a heavy lift there. So it is prior authorization that has varying documentation. I mean, we looked at the heavy lift here with the documentation to help support appropriate utilization, and whereas, you know, your recommendation is it's a cardiologist saying my patient needs this. So I think that's the bigger determinant of whether the patient gets access to drug therapy.
Yeah, I don't think it's the channel, and the channel comes, there are other reasons on mandated specialty pharmacy, et cetera. But I do agree that the SP is more equipped to navigate
Yeah.
the approval process.
And
than
then
a retail
Jennifer's
pharmacy.
example, you know, she's got a patient got approved for a drug like that because of family history, but it's $300 out of pocket per month.
Mm-hmm. That's what statins used to be before things changed. Now let's take a look into the future. I want you to anticipate outcomes data for me. Make a guess. If you want my guess, it's going to be good. Outcomes data shows that these drugs really work, that the LDL of 30 is better than an LDL of 80. The side effect profile looks good. The decrease in heart attacks that we've already documented, the decrease in strokes that we've already documented, this is all to the better. Decreased death rate. Once we get that data, that outcome data, what's going to happen to access from your side?
It's still about appropriate patient, so we have to change the definition of appropriate patient. So it's probably going to expand the number of patients eligible for these
Right.
drugs. It's probably going to move into primary care and a number of other things. The challenge is going to be strictly from a cost efficacy perspective, from a quality adjusted life year, however you want to look at that. These are not cost effective. So it still is about appropriate patient. It's just the definition of who that patient is probably has to change.
But what do you mean they're not cost effective? If they're lengthening life, if what the outcomes data shows that the death rate's reduced when you use these drugs compared to not using
In an
them.
individualized patient, absolutely cost effective. Across a population with numbers needed to treat and quality adjusted life year, and all of the other cost effective analyses that you can apply to this, by definition, they are not cost effective.
And here comes the specter that every doctor and every payer deals with every single day. We've unroofed it again. We unroof it on every broadcast, by the way, which is, who do you care about? When you're sitting across from a patient, do you care about the society cost of this drug, the cost of the payer of this drug, or do you care about your patient's well-being exclusively?
Well, the answer to that to the prescriber is going to be the patient. And you know, certainly you want to be cost conscious to the patient and to society, but you're going to care only about that patient and getting that patient the correct medication.
But if they have skin in the game, then maybe it's a different question.
Well, and I think it still gets back to that whole silo effect that we talked about in the very beginning. I mean, if I'm going to give this patient with ASCVD or CAD this drug, and it's going to prevent them from dying, you know, and that patient in front of me, you know, we're talking about risk, and we're going to play the gamble. You may not be the one that dies from an MI early or whatever. You know, we're going to treat that patient. We're going to be aggressive. Well, if we prevent one event, how much money do we save? The overall health system, despite we're spending more money on the medication. I
So
think
the
that's kind of
analysis that you're doing to say that it's not there's no cost benefit from a population perspective. Does that take into account the avoided cardiovascular events?
Yeah, it's a reduction in events.
But it's across population
Right.
as
So,
opposed to an
yeah, so
individual
my
patient.
answer is we care about all of the above, right? So we have formularies and premiums and everything else by nature are population tools. But there has to be avenues in place, and that's the PA, and that's the care management, other things to manage individual patients. So on an individual patient perspective, these are cost effective if it's appropriate. Across the population, what I'm saying is if you get these drugs in patients who, again, aren't on a statin, who don't have FH, then are they really
I mean, look,
serving the society?